Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry X-Line Ziegler Fund. Thanks for being with us. And I've got a friend with me here tonight, Dr. Shankar Raman. Dr. Raman is the Chief of Surgery at MercyOne, and he's a colorectal cancer surgeon. So welcome.
Thank you for having me.
Well, thanks for being here. So how does one grow up to be a colorectal cancer surgeon? Was it something you decided like in kindergarten you wanted to be?
No, I'm the first in the family to go into medicine, family of engineers and teachers. So interested in medicine towards the end of high school, and I went to med school in India. No real understanding of what it takes to become a physician or to care for patients who have health issues. It was just that it was on the radar, did well in school, and went into med school straight from high school. So too immature to really understand what it takes.
So going to high school in India, clearly you came from a family with a science background and you're probably strong in science in high school. Is there that expectation that at a young age and that you kind of know what you go? Do you go
No.
go right from high school into a career-oriented higher education?
Yes, if you're really good in school, then the expectation was that either you became an engineer or a doctor. And that was the ticket out of poverty for most families in India, or for that matter, in low-income countries. So did well in school and was able to get admitted to a very prestigious medical school in India. And boy, that was some awakening.
And how many years is medical school?
It's 5.5 years.
Okay.
5.5 years, including 1 year of compulsory internship. And you need to complete that before you graduate out of medical school.
So I think back to ancient history when I was in medical school, and it's sort of it seemed like you either were figuring out you're going to be more of a surgeon or more of a internal medicine type focus, that there were those folks who were, really good at using their hands and doing things with their hands versus those who felt that they were using their brain instead of their hands. That's not a fair comparison, but was that sort of a dichotomy of how you might go when you're in medical school when you went through it?
Yes, very, very similar. But I got attracted to surgery towards the end of my 4th year of medical school, given, it's nearly 5.5 years of medical school training. But during that 1 year of internship, you do have rotation in surgery. And that's where I really felt that, this was what I wanted to do. So that's how I got interested in surgery.
So then you finished medical school, and then what was you do a general surgery residency?
Correct. Yep. 3 years of general surgery residency in India, and then got certified, and then worked for about a year and a half after that in the same medical institution. Did other specialties as well, just figuring out what my true interest was. Did some general surgery, did some pediatric surgery, did some urology, and then decided that I wanted to go and see the world.
Okay. And so where did you do your colorectal cancer fellowship?
So that was at Henry Ford in Detroit, after 5 years of general surgery training in New York City.
Oh, so when you came to the United States, you had to redo your general surgery.
Yep,
so 5 more years of general surgery, and then
a year of colorectal fellowship at Henry Ford.
Right. Yeah. And you came to MercyOne how many years ago?
It's about 11 years now. Completing 11 years. Yeah.
Wow. Wow. And so Dr. Raman and I have worked together for 11 years, and he was instrumental in getting MercyOne Des Moines to be one of the very first cancer centers in the United States to be certified by the Commission on Cancer National Accreditation Board for rectal cancer.
That's right.
Very prestigious designation, and one that isn't given out lightly, that indicates the excellence of care that we have. And rectal cancer is really one of those cancers that is truly multidisciplinary. We say that a lot, meaning it involves surgery, chemotherapy, radiation therapy. Maybe explain a little bit for those who may not know the difference between, what the colon is and what the rectum is, and in general, some of the commonalities and differences between colon cancer and rectal cancer.
Sure. Yeah. The colon is a medical word for the large intestine, and the rectum is the last 6 inches of the large intestine, essentially a place that stores waste and we eliminate it. The colon is about 4.5 to 5 feet long, including the rectum, and the rectum is the last 6 inches. So colon cancer usually is treated with surgery upfront unless patients have stage 4 disease, meaning the cancer has spread to other areas, in which case we treat them with chemotherapy. Certain select situations where even stage 4 disease can be treated with surgery, where we get rid of all the cancers and we can achieve cure. There are also situations where patients start with stage 4 disease. They have little spread of disease within the abdominal cavity. We call it as carcinomatosis, where even in those situations, surgery is an option, cytoreductive surgery, and we put chemotherapy into the abdomen, heated chemotherapy, and we are able to achieve control of the disease if cure is not possible. The rectum is different because, in my mind, and in pretty much all colorectal surgeons' minds, you get one good shot at taking care of rectal cancer. It is a disease where you don't have many opportunities to kind of reconfigure your options.
And that's because anatomically, it's
Correct.
way down in the pelvis,
Correct.
right next to the bladder, right
Correct.
next to the men, the prostate, or women, the uterus,
Right.
and right where all those muscles that control the function.
Absolutely. Yeah, it's because the situation and or where it is located, as you said, within the bony pelvis, surrounded by bones and very important, crucial organs for reproduction, quality of life, sexual activity, urination. So the treatment for rectal cancer needs to be tailored for each patient depending on the stage, and which is where I think the multidisciplinary tumor board makes a huge difference. As you know, I'm a strong believer in the team making the best decisions for a patient rather than just one pair of eyes or two pairs of eyes. Truly having different thought processes and different perspectives on management of cancer helps deliver the best treatment for any patient.
Okay. So I jumped right into sort of defining the difference between the colon and the rectum. Let's back up a little bit and talk about colorectal cancer. What causes it? Which individuals are at increased risk? How do we find it? It's one of the 5 cancers for which we have a screening
Correct.
test available. So maybe talk a little bit about what we think are some of the factors that put people at increased risk for developing colorectal cancer.
Sure. Colorectal cancer, the risk factors for colorectal cancer, age is still the number one risk factor. This year alone, more than 150,000 Americans will be diagnosed with colorectal cancer. The increase in colorectal cancer is predominantly in the younger population. When I say younger, it is less than 50. And more importantly, between the ages of 35 to 45 is where it is increasing. The reason is in the older age group, we have been able to implement screening to capture polyps before they turn into cancer and remove polyps. So the incidence of cancer in the older population is going down, whereas in the younger population it is increasing.
Right. And so just to explain that a little bit further, that most screening tests just find a cancer at an earlier stage, but colonoscopy, that may be a procedure that prevents cancer,
Correct.
because in the act of looking for a cancer, you might remove a polyp that isn't cancer yet, but removing it, it actually prevents it from developing into a cancer.
Absolutely. Yeah. Colonoscopy is not just a screening technique. It is also, as you said, a therapeutic or a treatment technique where we remove polyps before they turn into cancer.
Mhm.
And that has been well studied that a colonoscopy can prevent polyps from turning into cancer over many
Yeah.
years.
So unlike like mammograms, which is screening for breast cancer, mammograms can find a breast cancer, but mammogram certainly doesn't prevent breast cancer.
Correct.
But a screening colonoscopy not only can find a cancer, but it actually, by going through regular colonoscopies, you may actually prevent a colon cancer.
Absolutely. Yeah. Yeah, that's true. So, as a screening technique, colonoscopy is head and shoulders above others, because it can also take care of polyps. That being said, the best screening technique is the one which gets done.
So what else, what other techniques are screening techniques for colorectal cancer?
There are stool-based techniques where patients have to send in a sample of the stool for testing. It used to be called stool guaiac, where they would check for blood in stool, but that has improved to the point where we check for DNA, which is a component of the cells of the nucleus within the cancer cells that is secreted in stools. We check for that. It's called as the Cologuard commercially. That's the test that we use, and that's a non-invasive test, easily mailed from
Yeah.
home.
So you send in a sample of your stool, and we have now the ability in the laboratory not just to test for blood in the stool, but actually to find cancer cells DNA
Correct.
in the stool.
Correct. Yep. So that's how advanced we've become over the last few years, and it's easily done from home. And there are certain situations where it might be a false positive, but that is a very small number. A positive Cologuard typically needs a colonoscopy to look inside the colon and figure out what's going on.
Okay.
It might not be just a cancer that can cause a positive Cologuard. It might be a large polyp that also can shed DNA, and the Cologuard is positive. But what colonoscopy does is we can take care of the polyp and remove it and prevent it from becoming cancerous. So that's a win.
So back to what causes colon cancer. What are some of the lifestyle or inherent characteristics of individuals? You mentioned age, that we're seeing colorectal cancer at younger ages. What are some of the characteristics of people that put them at higher risk for
Sure.
developing colorectal
Sure.
cancer?
Great question. So family history is an important one. Anyone with a first degree relative with colon cancer, a first degree relative is parent or brother or sister or sibling, or a child of somebody with colon cancer that got diagnosed before the age of 60. That puts the first degree relative at a higher risk. Or if you had two first degree relatives with colon cancer, irrespective of the age, that puts you at a higher risk. Other risk factors, lifestyle, include smoking as well as alcohol intake. That is a big component. Lack of physical activity, a sedentary lifestyle is a big component, and diet plays a huge role because this is in the intestine. Consumption of ultra processed foods, red meat, um, puts at a higher risk for developing colorectal cancer. One of the areas where research is being done, we had Dr. Nelson from the Commission on Cancer talk about this a few years ago, is the role of microbiome and understanding how that affects the risk of developing colorectal
Explain
cancer.
what the microbiome is.
The microbiome is the word used to define the conglomeration of all the minute bugs, bacteria, as well as others living inside the gut of living inside our gut.
And we got a lot of
Lots.
bacteria and
Trillions of them.
trillions.
Yeah.
Yes.
Yeah. So they have a role in,
And they're not
development
all
of-
bad guys.
correct.
Many of them are good guys,
Correct.
helping with digestion, but probably with lots of other things that we're still learning about.
That is true. That is true. We still don't know how they play or what sort of a role they play. And as you said, not all of them are bad. Some of them are absolutely needed. We find them in probiotics that are helpful for regulating gut function. So,
And there's some theories that are which bacteria we have and what proportion might influence whether someone is obese or not.
Right.
That it's not just related to how much food or what type of food, but that maybe the population of bacteria might influence
True.
our body habitus.
Yep. They also regulate metabolism, to see how one processes food, how much of absorption versus waste. Studies are also coming up showing that microbiome plays a role in how our mood functions. In neurological conditions or psychiatric conditions, microbiome also has a role, and that's an area that is being researched. We don't fully understand it yet, but we know that there is a gut-brain
Mhm.
relationship or gut-brain axis.
So there's this thought that, obviously the waste product, this is stuff that the body is eliminating, and that there's bad stuff in it, and that the longer it hangs out in the large intestine, the longer it's in contact with the intestine, that maybe it causes bad. So the question is, do people who have slower elimination, problems with chronic constipation, does that put someone at a higher risk for developing colorectal cancer?
Not really. Just the fact that somebody has chronic constipation does not put them at higher risk. But it might be conceivable that there are other factors in play that we don't know of. It might be associated with a sedentary lifestyle, that could be associated with
Mhm.
constipation. It could be associated with, obesity sometimes. Not causation, but it might be that there are other factors that might be associated with chronic constipation. But we might think that, oh, it's just the longer interaction between the waste and the intestine that causes colon cancer. But studies haven't supported that.
Okay, so I'm on YouTube looking at some medical lectures, and they pitched me this ad that this miracle cure for having regular bowel movements. They say, it's not. Has anybody else experienced this? You get pitched this, and it's like, it's not the fiber, it's not this or this, it's just this, and hang on for 5 more minutes, and we will tell you that this is all you have to do every morning to have a regular bowel movement every morning. But I've never watched it through. So what is the secret to having a good, now, as a colorectal surgeon, you've got to be the expert on pooping.
That's right.
What is the secret to that good morning poop?
Yeah, as a poop doctor, I can tell you that there is no secret sauce.
There's no secret.
Sauce. Yeah, it's the frequency of having a bowel movement varies from people to
Mhm.
people. It might be once a day in most. It might be twice or even 3 times a day. Only when it is loose, consistently watery, then we call it as diarrhea, and that needs further testing. And sometimes people might have a bowel movement every once in 2 days or so. As long as they don't have that sensation that something's there and it's not coming out, that's when we call it as constipation, or a sensation that there is, an obstruction. It is not, it's still considered physiological, still considered normal. So there is no secret, or there is no mandatory number of bowel movements per day one needs to have.
I have this theory that if everyone in the world had a good bowel movement every morning, there would be world peace. What do you think?
I would like.
I would say, let me alter that. A good night's sleep and a
True.
good poop. That if all the world had a good night's sleep and a good poop in the morning, there would be world peace.
Yeah, I wouldn't disagree with that. I would also say that, regular physical activity would facilitate a good night's sleep.
Yes.
And with gut movement.
Good. So
Yeah.
physical activity. So back to, we were talking about causes of cancer. So, having a family history, which may indicate that you might have a genetic mutation that predisposes you. And maybe talk a little bit about Lynch syndrome. I
Sure.
went to medical school at Creighton
Yeah.
University,
Yeah.
and Henry Lynch, Dr.
Yeah.
Henry Lynch, was one of my teachers, and one of the pioneers in helping to determine that there are clusters of cancer in families that ultimately led to learning about genetic mutations that we may have that predispose us to cancer.
Yeah. And our understanding of the mutations that cause Lynch and how to test them and what cancers are associated, it's increasing day by day. Lynch syndrome is a condition, typically it is described as non-polyposis colon cancer. Hereditary non-polyposis colon cancer is the technical term that is used. But as you said, Dr. Lynch, identified the cluster of families. Even in these patients, they start out as small polyps, but they are difficult to see as compared to the regular polyps. They are more flat. They are very subtle, and we use a different light during colonoscopy to identify these polyps, and we can remove them and prevent them from developing cancer. Lynch syndrome is also associated with other cancers. So, typically in a cluster of families, one might see colon cancer associated with endometrial cancer in a female. First degree relative might be associated with small intestinal cancer, might be associated with kidney or urinary bladder cancer. So, those might be some of those cancers that can occur together in a cluster.
Okay. And if you are part of a family with that has Lynch syndrome with mutations, should you be screened more often? Should you have your colon removed before you develop cancer? What are some of the concerns for those individuals who do have the mutation that's part of the Lynch syndrome?
Yeah, great question again. So, Lynch syndrome, typically we start with screening with the colonoscopy every 1 to 2 years. High quality, good quality colonoscopy, which means that the colon was well prepped. The scope was done by somebody with a lot of experience and can get to the beginning of the colon, and making sure that they spend sufficient time to look at the colon. So these patients, every 1 to 2 years, they need to undergo a colonoscopy. Also, patients, in a family with a history of Lynch syndrome, they have the option of genetic testing, and undergoing genetic testing can tell us exactly which gene is mutated, and specific gene mutations are associated with certain increased risk of certain cancers. So depending on the gene mutation, we can tailor the screening to look at focused areas and not look everywhere else and waste resources and cause unnecessary anxiety. Only when patients develop cancer in the setting of known Lynch syndrome, meaning, known Lynch syndrome with colon cancer, would recommend removing a portion of the colon or maybe the entire colon, depending on their age. Studies show that, for those under the age of 65, there is a survival benefit in removing about 80 to 90% of the colon and bringing the small intestine and hooking it to the rectum. Whereas in older patients, they may not need that aggressive surgery because the risk of developing cancers for the lifetime that they have left is small, and the colon can be kept under surveillance with a colonoscopy.
So just like some women who have the BRCA mutation for
Right.
breast cancer may have both breasts removed to reduce the risk, some individuals with Lynch syndrome who have a colon cancer may actually have most of the colon removed,
Right.
to prevent future cancers from
Correct.
happening.
Correct. Yeah.
Okay, let's talk a little bit more about the treatment. So let's say, at what age should someone who doesn't have a family history of colon cancer, at what age should they start screening for colorectal cancer?
45.
Age 45.
Yep.
And that's a
45.
recent change.
Correct.
Because, as you said, we're starting to see colon cancer at a younger age. So it used to be age 50.
That's right.
And so now we should start screening at age 45. So I go in to get screened. You do a colonoscopy and you find an abnormality in my colon. You biopsy it and it's cancer. And I wake up, and do I find out that day, or when do I find out that you found cancer in my colon?
So depending on how it looks, if it is very similar to a polyp, we can't tell just with our eyes, how it looks. So every polyp that is removed is sent for testing, and we get the results from the lab in a few days, maybe up to a week. And then, the lab will tell us whether it's cancer or if it's just a precancerous polyp. Sometimes, just based on how it looks, we have a suspicion that this looks like cancer, and we can tell the patient right then and there, hey, this looks like cancer, but we still need confirmation from the lab, which we will get in a few days. And depending on that, further testing and treatment options are there.
Mm-hmm. And so that would be a screening colonoscopy. And again, screening colonoscopy, I don't have any symptoms of colon cancer. just because I'm of the age, I get a screening and get looked at. Now, a diagnostic colonoscopy, if I've got problems having bowel movements and I've got blood in my stool, and you go do a colonoscopy, that's a different situation.
That's correct. Yeah. Yep. Screening, no symptoms, and diagnosis is only when patients have symptoms. It might be change in bowel habits, it might be diarrhea, constipation, blood in stools, or change in caliber of stools. Sometimes the stools can be thinner, like a pencil or a ribbon. Those might be situations where the colon, the pathway is getting narrowed due to a tumor developing, and we do a colonoscopy to see what is causing the change in the caliber of stool.
Gotcha. So symptoms that would lead to getting a diagnostic would be blood in the stool,
Right.
change in the shape or diameter of the stool,
Right.
Constipation,
Constipation, sometimes diarrhea, sometimes just abdominal pain. And many times in older patients, especially those who present with right-sided cancer, they may not see blood and stool with their eyes, but they might be anemic because there is microscopic blood loss in stool. So when their regular doctor tests them for hemoglobin, that might be low, and they might be looking pale, or they might feel weak and tired. And anemia, typically iron deficiency anemia, is how right-sided colon cancer is present.
Right. So the doctor finds that they're anemic, then, okay, let's check to see if there's any blood in the stool. And then that may lead to the discovery of the colon cancer. So we've discovered my colon cancer. Talk to us a bit about colon cancer surgery, and how it has changed over the years. And what is this thing called robotic surgery?
Yeah. Colon cancer surgery is where we remove about 6 to 8 inches of the colon, typically, along with the lymph nodes, in order to make sure that we get a good staging for the cancer. Depending on the lymph nodes, if they are positive with cancer or not, then the stage is either stage 3 if the lymph nodes are positive, or stage 1 or 2 the lymph nodes are negative. Surgery, as I said, involves removing 6 to 8 inches. About 15 years ago, we did them open open surgery, 10 to 12-inch long incision on the abdomen, and we removed the colon and put the ends back together by suturing or with staples. And patients stayed in the hospital.
So you basically opened them up and you got in there with your hands.
Yep.
Yep.
Just with hands.
And now robotic is where you and R2D2 and C3PO
and BB8,
are no. So robotic, what's the robot part?
So the robot part is where I sit on a console. It is like playing a video game with 3D vision, where I control the instruments that I place into the abdomen, and I have full control all the time. It's not like a robot that's going to run amok. So it helps me see better, 10 times the magnification. It helps me see where exactly the cancer is. And because we go through incisions that are probably 1/3 to 1/2 of an inch, patients have less pain, faster recovery. They're able to go home sooner, and they're able to go back to their normal activities sooner. So the quality of life, return to work, all that is really outstanding. With minimally invasive approach, of which the robot is overtaking laparoscopic approach now.
And any other techniques that are new in terms of colorectal surgery?
Yes, we can remove early stage rectal cancers just through the anal opening, where we don't have to cut them open and remove them. And sometimes in the past, some of these cancers were treated with a big operation with a permanent colostomy bag. But with advances in techniques and advances in understanding that some of these early stage cancer did not need or do not need aggressive treatment, we are able to remove them just going in through the anus, cutting them out, and watching them closely, and thereby avoiding major life-altering changes for the patient.
So most of the time, colon cancer in its early stages, surgery doesn't require a colostomy. When you get down to the rectum, there are some times where it's so low that you actually have to do a colostomy because you can't keep enough of the rectum to be able to have control of
Yep.
bowel movements.
Yeah, the rectum is 15 centimeters or 6 inches. When we get to half the rectum out, there is not much storage space. So patients have life changes. They have to go more often. They might have to go more frequently, meaning, every 15 minutes for within an hour, they might have to go for 1 to 2 hours in a day. And they might have accidents and they might not be able to hold the waste in. So that makes a huge deal to affect the quality of life for patients. And especially when the cancer is affecting the sphincters, we have to remove the sphincter to achieve cancer-free, resection. So in those situations, having a colostomy is much better because it gives them freedom and it gives a good quality of life and the ability to go about their life without having to see where the bathroom is all the time.
Mm-hmm. And is there anything new in terms of colostomies? Because I think of like patients who have to have their bladder removed, and there's some newer reconstructive surgeries where instead of just a constant leakage, you sort of have a little bit more control over when you empty it. Obviously, the stool is much more difficult than urine. Is there anything new in terms of uh, those patients who require colostomies and how colostomies are being done?
Yep. So even before we get to a colostomy, there are certain new techniques or certain, I would say, techniques that are available to increase the storage space. Rather than bringing the straight colon and hooking it to the anus, we can create a pouch of the colon that gives slightly more storage space and hook it down to the anus. But that, beyond a few years, it doesn't give as much storage. Now with the colostomy, I have this fascinating patient who is in her 80s, had to have surgery, had a colostomy, and what we are able to do is irrigate the colostomy every morning. You said a good bowel movement in the morning, so irrigate.
So by irrigate, you put some salt water in, or just regular tap water?
Regular tap water, put a catheter, irrigate, wait for about 30 minutes, and everything comes out. Doesn't even wear a colostomy bag, just puts a dressing up on top and goes about super active, plays golf, pickleball, you name it. And life, it hasn't changed much for her. So those are options that are there for the moon. If somebody is motivated and wants to understand and adapt, yeah.
But it would be a true statement that most people who have colorectal cancer do not have to have a colostomy.
Absolutely. Yeah. Most patients, with advancement in techniques in our understanding, we are able to avoid colostomies for the most part. And we save colostomy surgeries only in the rarest of situations where there are no other options available.
So when do patients need to have chemotherapy? And under what circumstances might you do the chemotherapy before you do the surgery? And what circumstances might you do the chemotherapy after the surgery?
Yep. So typically for colon cancer, chemo is done after surgery when we do the operation and we find out if the lymph nodes are positive. That's usual. Recently,
and if the lymph nodes are positive, that would be an indication to do chemotherapy after the colon cancer surgery.
Correct. Yes. Yes. After surgery, if the lymph nodes are positive. But recently, a few trials have come out that show that even patients with colon cancer with advanced disease, where it looks bulky, where it looks that the lymph nodes might be affected on CT scan, we have moved towards giving chemotherapy before surgery to shrink down the tumor and to make surgery more successful. Also, these patients, when they receive chemotherapy before they undergo surgery, they are able to receive the full dose of chemotherapy and have less GI side effects that chemotherapy typically brings.
Okay. And then what about rectal cancer?
Rectal cancer, early stages, we can treat it with surgery. But if it is going through the wall of the rectum, or if the lymph nodes seem to be involved on the MRI scan, that's when we put our heads together. That's when we discuss each patient at the multidisciplinary tumor board. And if those two situations are there, meaning lymph nodes are positive on the MRI or the tumor seems to be going through the wall, we treat them with chemotherapy and chemoradiation upfront, with the whole idea to shrink down the tumor, make it as small as possible so that surgery is successful. And in some situations where we can avoid a permanent colostomy.
Mm-hmm. So if you can shrink the tumor down, you might have a better chance of totally removing it without the need for a colostomy.
Correct. Yep.
What are some of the advances that we're seeing in, I hear things about precision medicine um, and circulating DNA. How do you see the advances in laboratory medicine and learning more about the tumor? Maybe explain a little bit about precision medicine and about finding bits of cancer in the bloodstream.
Yeah. So the ctDNA, or the circulating tumor DNA, is a test, is a blood test that is used to check the level of tumor within the body after patients have undergone surgery. Our understanding of this is evolving, like most advanced research. We are currently using this in conditions where patients have undergone testing, have undergone surgery, cancer has been removed, and we want to keep a close eye on those patients where we think the cancer might come back. So it is more sensitive in picking up the cancer before the cancer shows up on the CT scan or on a PET scan.
Gotcha. So the old-fashioned way of trying to keep a patient under surveillance to see if the cancer were to come back might be to do a scan, to do a scope.
Yep.
And now we're learning that we might be able to find the first sign of a cancer recurrence by doing a blood test and finding little bits of tumor cell DNA in the bloodstream.
Yep.
As the first sign of a recurrence.
Yep.
It's pretty amazing.
It is pretty amazing.
Yeah.
One of the other things that you asked me about precision medicine is the report in the NEJM, New England Journal of Medicine, that came out last year on using immunotherapy in patients with Lynch syndrome with rectal cancer who got treated with immunotherapy, and all 21 patients had complete resolution of cancer.
And explain the difference between chemotherapy and immunotherapy.
So chemotherapy essentially just targets cells that are dividing fast. Cancer cells divide faster as compared to regular cells. So chemotherapy acts on those fast dividing cells.
Medicine that directly kills cancer cells.
Correct. And immunotherapy is based on testing that we do on the cancer cells and see if they have a mutation in them at the genetic level, and treatment targeted towards addressing or fighting the genetic mutation. So it targets only those cells that have the mutation in the body. So it doesn't target other cells, so toxicity is less.
Mm-hmm. So fewer side effects. Where do you think we're going to go in the world of colorectal cancer? Do you think we can develop things to prevent colorectal cancer from developing? I know there's some studies looking at maybe some anti-inflammatories might prevent cancer. Well, what other research are we looking at to see what can we do to prevent colorectal cancer?
The use of anti-inflammatories, as you said, aspirin and Sulindac are the two medications that have been recommended. We used to think that aspirin was totally effective, but we don't really know for sure. So aspirin is used in select situations. The role of aspirin in patients who have a Lynch syndrome but haven't developed cancer, it is still out there. I can't say that it's 100%, advocated or used. Similarly, in familial adenomatous polyposis, the role of aspirin is kind of debatable. Again, these cells work by increasing, by preventing those cancer cells developing in the colon. If I had a crystal ball and had to predict, I think precision medicine and immunotherapy will become more the norm. Every cancer will undergo genetic testing and identify markers so that treatment can be directed just at the cancer cells and sparing the other cells. So as you said, the side effects will be significantly lower. In the area of rectal cancer, one of the things that we didn't talk about was watch and wait, where we have gotten to the point where patients don't need to have surgery, but they can be treated just with chemotherapy and chemoradiation and avoid surgery because surgery is associated with life-changing consequences and a permanent stoma. I think the watch and wait would be something that takes more prevalence as we figure out which cancers might be more suitable for that.
Good. And so that's, again, talking about rectal cancer, where we would do chemoradiation. And when the chemoradiation, instead of following it up with surgery, we find that the chemoradiation made all the cancer go away.
Yeah.
So instead of removing the rectum, we say, gosh, maybe the chemoradiation was enough.
Yeah,
And so then we watch very closely
that's true.
by you doing a scope
Yep.
frequently every 3 months
So,
or
so every 3 months for the first 2 years, along with an MRI scan as well as a blood test to check the level of tumor in the body, as well as a CT scan every 6 months. Most cancers, if they should come back, they come back within the first 2 to 3 years. Beyond that, we can stretch out the intervals, and we have been able to avoid surgery in many patients by adopting this approach. And again, the data on how frequently they should be evaluated, what sort of treat or evaluation modalities, how frequently the scope, the scans must be done. It's all being parsed out.
so to kind of summarize, we want to prevent the cancers that are preventable. So let's say for people who don't have a genetic mutation, I would say we want to eat healthy, maintain a normal body weight. We want to exercise regularly. Um, do we want to increase fiber in our diet, fruits and vegetables?
Yes.
Reduces the risks.
Right.
So those are things we can do to prevent it. Then when we want to find it, if by screening, and so at age 45, we should start having screening, and that should either be stool testing or colonoscopy.
Correct.
Both acceptable ways of screening. And then when we have cancer, we want to get treated at a center that has multidisciplinary care with colorectal surgeons, dedicated colorectal surgeons, medical oncologists, radiation oncologists.
Absolutely.
What age do we stop screening for colon cancer?
Um, Medicare recommends that beyond 75 years of age, screening should be decided, at the individual level between the individual and the primary care
Mhm.
provider. That being said, I have patients in their 80s who are healthy, who have who do not have any major issues, who want to undergo screening, and I do colonoscopies on them. Studies show that as long as there is a life expectancy of at least 5 years, screening could be considered as an option.
So if someone's a healthy 75-year-old, hasn't had 3 heart attacks and 2 strokes, and so if you expect that their life expectancy is more than 5 years, they may actually benefit.
Right.
So as a colorectal surgeon, your life isn't just about cancer. So what are the other conditions that you see that make up your practice as a colorectal surgeon?
Yeah. So I use the word poop doctor. That's what my nephew calls me or called me. When he was a toddler. So other than dealing with cancers, diverticular disease is another condition.
So diverticulitis,
Diverticulitis,
diverticulosis,
both. As well
okay.
as diverticular fistula that arises from a complication from diverticulitis.
And what's a fistula?
It's a connection between the colon and other structure. It might be the bladder, it might be the vagina, or it might be the skin, where the colon ruptures and patients have stool coming out of their skin, or when the colon ruptures into the urinary bladder and stool comes out in the urine and air comes out in the urine. Not conditions that people really want to talk about. In addition, other anorectal conditions, hemorrhoids, abscesses, fistulas, including fecal incontinence, where patients cannot control their bowel movements, we offer treatments, including newer methods that make a huge difference and improvement in quality of life.
Mm-hmm. So I know that as women get older, loss of control of the bladder is really, really common. Is the loss of control of stool more common in women than in men?
Yes.
Uh-huh.
Yes. That's because most women bear children, and children delivered vaginally. There might be birth associated trauma to the perineal area that can cause muscle damage. And also, muscles get weaker with age. Also, it might be that as the bowel movement changes, loose stool is harder to control as compared to harder stool. So those might be some of the factors that play into this. That being said, about 7 to 8% of the population has fecal incontinence, and it's a very touchy subject. We don't want to talk about it. And there are treatment options that are available for patients with fecal incontinence.
Mhm. Okay, let's open it up for questions. So we have a live studio audience. We also have a live virtual audience. So the poop doctor is in. It's your opportunity anonymously to ask any question you want of Dr. Raman about colorectal cancer, about pooping, or about anything to do with the colon.
Absolutely.
Fair game. Okay,
I'll
we've
go
got a-
first. So someone that just went to a treatment and you took lymph nodes out, side effects, what do you see? Do you see lymphedema in the legs? And
Not with colon cancer surgery. It's a great mechanism of how the body is built that we don't see any of those consequences, because the part where the lymph nodes drain is also removed. So essentially, there is no organ to develop lymphedema.
So unlike breast cancer surgery, where removing a bunch of lymph nodes might increase the risk of developing swelling of the arm, when you remove lymph nodes with colon cancer, it doesn't cause any swelling.
Correct. We don't see that.
Okay.
Yeah.
Question. There we go. Angela. Okay. Either way. we've got
Okay.
time.
I have a question about the red meat.
Yeah.
What is it about the red meat that it's not advised? I mean, I was advised when I was going through my breast cancer, no red meat, but it was never explained why not.
Yeah, we really don't know why.
Mhm.
We think it might be what is in the red meat that is associated with the increased risk of colon cancers. The processed meat, though, is because of the nitrite levels that is associated with increased risk of developing cancers. But truly, with just red meat, we don't know.
And then speaking of red meat, there's also some studies that the way you cook the red meat, that charred, grilled, might have more carcinogens, more likelihood of increasing the risk
Right.
of cancer than
Right.
than other ways of cooking it.
Correct.
Didn't know that. But I have one more. I'm asking about hemorrhoids.
Yeah.
I know my mom's not alive anymore, so I don't think she matters if I ask about this, but she used to get a lot of that. Was that something we should have been worried about when she had that problem, or is that just normal? And she was in her 70s. when
What
this happened.
causes hemorrhoids?
Yeah. Thank you.
Yeah, great question. So hemorrhoids, all of us have hemorrhoids. Even newborn babies have the hemorrhoid tissue. Colloquially, we use the word hemorrhoids or hemorrhoid issues when they get big, they swell up, and they bleed at the end of a bowel.
And they are
movement.
blood vessels. Right?
Correct.
So a hemorrhoid is a blood vessel,
Yep.
a vein.
It's more of a arterial blood vessel. Yeah.
Oh, okay.
Yeah,
It's
the-
more arterial
yeah.
than it is.
Yeah, that's why the blood
I
is
just
bright red.
learned something.
Yeah. And if you do an ABG on a hemorrhoidal blood, it is more arterial than venous. So yeah, it's just an area where the tiny arteries and the veins, are in the tissue, and it provides support to the anal canal. And when we strain because of constipation or because of whatever, they tend to get big. And when they get big, they can get easily irritated because they're just full of blood. When they get irritated, they bleed. They can all be associated with itching. They can also be associated with swelling. So those are some of the symptoms. Should you be worried? Your bleeding at the end of bowel movement is not normal. And I've seen patients with hemorrhoids who bleed to a hemoglobin of 3 or 4, who are pale, who cannot function. So we want that to be taken care of. And it's the treatment for hemorrhoids is pretty simple, with minor changes, very similar to what we talked about for colon cancer. Healthy diet, fruits and vegetables, increasing fiber, lots of water, all that helps having a soft, regular bowel movement that decreases hemorrhoidal symptoms.
Does reading the entire Sunday paper while sitting on the toilet increase the risk of hemorrhoids?
Yes, it does.
It does.
So sitting for more than 5 minutes on the toilet increases the risk of hemorrhoidal swelling. And now with smartphones, everyone has one. People spend 30 to 45 minutes on the toilet, and these patients have a higher, they present more with hemorrhoidal symptoms.
Okay.
I've wondered if there's a remedy for how difficult it is now to get an appointment for a colonoscopy. I had a positive Cologuard test, and I've had cancer in the past, and they keep telling me it'll be several months before we can get you in for a colonoscopy. So that leads to lots of sleepless nights.
Absolutely. Yeah, I can see that. Positive Cologuard typically results in a colonoscopy pretty quickly, and we escalate it. We bring it to the top of the list and take care of it pretty quickly. So I'm somewhat surprised, but I'll be more than happy to facilitate getting the colonoscopy done.
Yeah, let's talk about this afterwards. So the point is that when you have a positive Cologuard, it's no longer a screening colonoscopy; it's a diagnostic colonoscopy, and that situation should put you at the top of the list. We'll see if we can help.
Yeah.
I don't know if the groups.
You don't have your scope with you tonight, do you?
No, didn't bring it in the
Okay.
car. Yeah.
I don't know if this group still exists. I had half my colon removed 35 years ago because of diverticulitis and was having trouble just with adjusting to it all. And at the time, there was the Des Moines Ostomy Club. People who had colonoscopies or cholesterol, whatever.
Yeah.
Colostomy.
Yeah.
Colostomies.
Yeah.
Yep.
And whatever the urine part was. But we met twice a month, and it was really good to see that you could make it through it.
Yeah.
And so if it's still available, I would suggest you continue to promote that too.
Do you have a support group for
Yeah. So
ostomy patients?
yep, there is a support group for ostomy patients. I do not know if it is still called as the Des Moines Ostomy Club, but plenty of options are available, through the hospital, through the clinics, where we can hook up patients who have ostomies, not just colostomies, might be urostomies or others, need the support and resources that they need to cope with living with an ostomy. Social media has a ton of information on that, and ostomy.org is a website that I commonly use to help patients, find resources on the internet for whatever complaints and challenges that they might have.
And most centers like ours have nurses that have advanced training in
Correct.
helping to manage ostomies and the supplies and the care of ostomies.
I also wanted to second, you had mentioned something about if you had enemas as you were going through this. I did not want to wear the colostomy bag. It
Yeah.
was messy, it was smelly, it was inconvenient.
Yeah.
And so I chose twice a day, and it's a very large funnel of
Yeah.
warm water that you let gravity do its job.
Yep.
And then you sit there for about 5 minutes and have a very large bowel movement.
Yeah.
But it's been 30 years. I did that in the morning and evening. And 30 years later, I still have 2 bowel movements a day within 15 to 20 minutes of that time. My colon got, I guess, a memory of when it should go. And so, I find that kind of amusing, but it did allow me to go back to work right away. And I didn't have to worry about, excuse me, I have to kind of, because it does regulate you.
So does our gut have a brain?
The answer is yes. But do we know how it works? We don't know that.
Mhm.
I think the next area of understanding, the next frontier, I would say, in understanding gut health is in the gut enteric nervous system, or the nervous system for the
Mhm.
gut, because that has not been well studied at all.
Yeah.
And we are beginning to understand where the pacemaker for the gut is.
Mhm.
How the bowel movements happen and whatnot. And thank you for sharing your experience. That is so fascinating that our body, each one of us, we have a cycle that our body regularly follows.
And who hasn't had a gut instinct?
That's right.
No, but seriously, there's neurologic connections that do connect our gut activity with our psychology, our emotions.
Yep. And I do see this in times of stress, as we are going through major stress, our gut can either shut down completely or might just become overactive. So the understanding behind irritable bowel syndrome, which can present with either constipation or diarrhea, again, is thought to be because of the gut-brain axis.
Kevin.
Yes.
Is there a relationship between Crohn's disease and colorectal cancer?
Ye-
Asking for a friend.
Yes. Crohn's disease is part of inflammatory bowel disease, and that is associated with a higher risk of colorectal cancer. So Crohn's disease and ulcerative colitis patients, they have a higher risk, and they need to be undergoing colonoscopies more regularly, more at shorter intervals, every 1 to 2 years, to ensure that they don't develop cancers. Yeah, thank you for asking. Very important question.
So a question, what does it mean to have a thread of cancer after having 18 inches of colon removed and over 30 lymph nodes also removed? A thread of cancer remaining. What is that?
A thread of cancer?
Thread.
That's what
Not
A
threat.
threat?
thread.
Hmm.
Yeah, like a small amount, I guess. I don't know. Yeah. That's what the patient was told, that they had a thread of cancer still remaining after that surgery.
So it is possible. So
Positive margin, maybe.
no, what I'm thinking is that if they had 18 out of 30 lymph nodes positive, it's likely they have microscopic cells in their system, and probably chemo is needed. Chemo is needed
Yeah.
to take care of it.
So we think that they're just using a analogy for a little bit, because that's
Yeah.
not a technical term.
Yeah.
A thread of cancer would not be a
Correct.
technical term. So it could be just this doctor using thread, meaning a small little bit of cancer.
Do you find that people with IBS tend to have colon cancer or rectal cancer?
So what is IBS, and does that increase the risk of colon cancer?
So IBS is a word, is a short form for irritable bowel syndrome, where the bowel can be irritable. It can either present with just pain that has been worked up, and we don't find a good reason for pain. Pain that gets better after a bowel movement. Pain that could be associated with either constipation or diarrhea and gets better with having, eliminating waste. It's a term used to describe a group of symptoms that we don't really understand, that we think is associated with the intestines. And we think it is how the gut is wired with the nerves that causes this. That being said, it is not, studies haven't shown so far any increased risk of cancer in these patients. It might be that because patients have a history of IBS, there might be some leaning towards ignoring some of those symptoms that might be associated with colon cancer. So one still needs to be vigilant and watch out for those symptoms.
Just one last question. You said that the age changed to 45. So does that mean that what's changed too is the recommendation? Like it's all normally like every 10 years. Is it still that, or has that changed?
It is still 10 years if there is no precancerous polyp on colonoscopy. If there is a precancerous polyp, we still recommend, depending on the number of polyps and the type of them, it could be anywhere from a year to 3 years to 5 years.
But that part of the recommendation didn't change.
Didn't change.
Okay.
So that has stayed the
That's
same.
good.
Correct.
Well, Dr. Shankar Raman, thank you so much for being our guest here tonight. So Dr. Raman, colorectal surgeon at MercyOne Cancer Center. And thank you all for being here. If you know someone that would benefit by watching or listening to this broadcast again, it will be available on demand at the Above and Beyond Cancer YouTube channel. And it will also be available on demand at the MercyOne Cancer Center website. Please join us again next week. Thanks, everyone.
Thank you. Thanks, Dick.
Thank you.